Good morning, good afternoon to everyone. Welcome to our TPUP. And I hope you are all having a nice time and you're all present here to listen to all our speakers. And I'm glad that there are many from the all over the Philippines. So we have from the University of Rizal System, and we have from Dr. Loma de Gato, Marilao, Bulacan, Dr. Joseph Tortona, and we have Dr. Romeo Tuason from Bataan, and also we have Dr. Josephine Pojeda, who's greeting us a good day to all. We have very interesting speakers for today, and I hope you all stay and watch and learn from all of these, no? And we have a lot of uh, um, we have a lot of speakers and interesting topics for today. And let's for so we are live streaming from TVUP YouTube channel, and we have our link, https://www.youtube.com/watch TV 9WP1567. And we have with us Dr. Raymond Sarmiento.
Thank you, Ma'am Stella. I'm currently in transit, but I'm very happy to be able to join for today's webinar. This is our 246. So magandang umaga po, magandang hapon, magandang gabi kung saan po kayo naroon sa mundo. This is our 246 episode, as I mentioned, and thank you so much for being able to join us. And thank you for our credible online community po, no? Ang pag-uusapan po natin for today will be the complexities of genito-urinary issues. OB-GYN naman po, ranging from infectious etiologies and inflammatory. This week's discussing prevalence, risk factors, and public health implications of various OB-GYN genitourinary complications. Po, latest advancements in diagnostic modalities, including advanced techniques and molecular management, and maybe a little bit of surgical corrections. So sit back and relax as we try to understand how do we gain a holistic perspective po, no, on managing chronic and recurrent genito from the health updates program. Very, very happy to be able to welcome you. Already given for speakers, ma'am.
Good afternoon, Raymond, and hello to all our participants here in the live broadcast of the Zoom webinar, and to all those watching via live streaming on the TVUP YouTube channel, as well as the UP System Facebook page, the TVUP Facebook page, and of course, all those watching from TVUP Signal TV channel 101. Our speakers this week are both serve as board secretaries of the Philippine Society for Urogynecology and Reconstructive Pelvic Surgery. Our main speaker is Dr. Mary Rani Cadiz, who is a faculty member of the Division of Urogynecology and Pelvic Reconstructive Pelvic Surgery at the UPPGH Department of Obstetrics and Gynecology. Our reactor is Dr. Ira Dominique Malonzo, who is the training officer of the Division of Urogynecology and Pelvic Reconstructive Pelvic Surgery of the same department, the UPPGH Department of Obstetrics and Gynecology. In this week's episode, we will discuss how we can elevate the standard of care and improve the health outcomes for all those affected by OB-GYN genito-urinary complications across the Philippines. But before we go to our presentation, Raymond will introduce our person on the street video.
Okay, thank you so much, Ma'am Stella. For our person on the street video, we asked our interviewees the following question. So number one, sa tingin po ba ninyo, ano-ano ang mga posibleng sakit sa matres? Paano po ninyo nalalaman na ang babae ay may problema sa pag-ihi? Ano-ano ang narinig ninyo ginawa nila para mawala ang problema? At sa tingin po ba ninyo, kailan dapat nagpapatingin sa doktor ang mga may problema sa pag-ihi? Please watch this.
Well, yes, may PCOS, endometriosis, partly is ovary, and part ba siya, I'm not sure, but cervical cancer ata is part, I think.
Top of my head, cancer, meron din UTI. Yeah. Ako personally, I have PCOS. I'm not sure if that counts.
Yeah, I'm lucky because I've only actually heard of them. I have no personal experience, but I know people who have what's called PCOS. It's quite complicated, no? Because it has so many symptoms that even if you don't know what you actually have, you have the symptoms.
From what I know, I believe pwede magkaroon ng cyst sa matres. Thickening ng matres kapag hindi nabuntis for a while or hindi nabuntis at all.
UTI, number 1 yan, may infection. Tapos, yun, usually may masakit, may pain somewhere pelvic or abdominal side of lower abdominal.
Some women, they experience a problem sa pag-iihi, lalo na after they've given birth. Parang frequent urination, minsan mahapdi din.
I don't know of anything specific to women, but I know that women and men, they get urinary tract infections.
Hindi siya fully related sa, yung what I know is, hindi siya fully related lang or limited sa women's health. Like, for example, I know na kapag may UTI sila, may hirap pag-ihi, gano'n. And if matatanda na, they sometimes pee themselves.
I think dapat drink lots of water, liquids talaga. Sana parang hygiene ng sa pagwawash din ng both male and female. Yun sa pagwawash, yung hygiene.
Hold it in as much as possible or parang nagsisearch na lang sila, ano pwedeng gawin. Kaya din sila bumibili ng mga adult diapers, stuff like that, if they experience leaking. Or if may pain, kung bearable, tinitiis na lang nila. I noticed na nagpapakonsult lang sila once they've had a push from loved ones, kumari kung hindi na talaga nila kinakaya yung pain.
Well, no, I'm actually of the school of thinking that when something's bothering you internally down there, I think you should go straight to the doctor.
Hindi na frequent yung pag-urinate mo. Tapos may pain habang umiihi ka. Tapos may discharge. Yan yung mga medyo kailangan mo na talagang magpatingin.
Pag iba na yung kulay ng ihi, that's a big red flag. And yun, if the pain is intolerable or kung sa bawat pag-ihi mo may pain, I think that's when you should get checked.
Okay, thanks so much to our webinar program team for taking care of the interviews. So just a little bit of housekeeping po, no? All certificates of attendance have already been sent out for webinars 1 to 245. So if you have any questions, please feel free to email us at our up.edu.ph email account. We also have been able to answer all of the questions that you may have about it. And especially for those who are asking like a renaming, just remember po, no, certificates of attendance are given to those who have watched at least 50% of the webinar duration. Okay, so for today, we follow our standard panel discussion format, and after our speakers have presented, that will be followed by a Q&A session. Okay, so we'll get the ball rolling. Dr. Stella Jose will be the one to introduce our main speaker for today.
Our main speaker is Dr. Mary Rani Cadiz, a faculty member of the Division of Urogynecology and Pelvic Reconstructive Surgery at the Philippine General Hospital, Department of Obstetrics and Gynecology. Okay, Rani.
Hello, good afternoon to everyone. Let me just share my slide. Okay. Okay. Is my slide visible?
Yes, ma'am. Go ahead.
Yes, very
Okay naman
clear.
po. Okay, good. So good afternoon, everyone, wherever you are. Thank you for tuning in to this webinar. So one of the most important aspects of patient care in obstetrics and gynecology is clear, honest communication, especially when it comes to discussing potential complications. Actually, it is applicable to any specialty. So whether the procedure is minor or major, it's our responsibility to explain all possible risks, including the rare ones like genitourinary complications or injuries. These problems may be uncommon, but they carry significant impact when they do occur. So, by setting realistic expectations, we not only uphold ethical standards, but also build trust. Informed patients are empowered, and that starts with full disclosure, no matter how rare the risk may seem. So today we'll focus on genitourinary complications in OB-GYN procedures. So one of the most feared but often under-discussed aspects of our field in OB-GYN. Our goal is to understand why these injuries happen, how to recognize them early, how to prevent them, and what to do when they occur. So when we say female genitourinary complications, well, it covers a wide spectrum of conditions involving both the reproductive and urinary systems, from infections and inflammations to structural issues. Some of the most common problems we encounter include urinary tract infections, actually recurrent ones, voiding dysfunction, and urinary incontinence. These aren't just clinical diagnosis. They can cause significant pain, distress, and negatively affect a woman's quality of life. So in today's webinar, we'll narrow our focus to three key areas. That would be voiding dysfunction, genitourinary fistulas, and bladder injuries. So these complications, while sometimes overlooked, are critical to recognize and manage effectively in OB-GYN practice. Genitourinary complications from the usual gynae procedures, while not extremely common, occur in about 0.2 to 1.19% of cases. Among these, the bladder is the most frequently injured organ, accounting for roughly 62 to 72% of cases. Ureteral injuries follow, with their incidence notably higher when electrosurgical tools are used. So these are our cauteries, particularly in both laparoscopic and open surgeries. These numbers highlight the importance of surgical technique, energy modality selection, and careful dissection to minimize the risk. I'm sure you're very familiar with the different types of obstetric and gynecologic procedures, as flashed here in your slide. But you know that they already carry a baseline risk for genitourinary injury. And that's because the structures, the reproductive and urinary organs, are very close to each other. And that risk rises in complex cases, especially with adhesions or distorted anatomy. So you could just imagine when urgency is added to the equation, such as in emergency cesarean section for non-reassuring fetal status or deteriorating maternal status. Or for example, there's a ruptured ectopic pregnancy with massive blood loss. The risk of genitourinary injury increases significantly. And in these high-pressure situations, limited time and suboptimal visibility can compromise the precision needed for safe dissection. This underscores the vital importance of deep anatomical knowledge and the ability to anticipate complications, even when every second counts. As I've mentioned, even the most commonly performed obstetric and gynecologic procedures, be it vaginal delivery, CS, or hysterectomy, carry an inherent risk of genitourinary complications. And this stems from the intimate anatomical relationship between the uterus, cervix, vaginal walls, bladder, and ureters, as you can see here in the picture. Now, these structures lie in close proximity, making them particularly susceptible to injury, especially in complex or high-risk cases. So it's important to emphasize that such complications are not always indicative of poor surgical technique, because that's what we usually hear. but rather a reflection of the challenging anatomy of the female pelvis. So understanding this relationship reinforces the need to approach every case, even routine ones, with vigilance, precision, and respect for the surrounding structures. So here's another view showing the relationship of the bladder and the ureters to other pelvic structures. So you can see here that the cervix, actually the uterus, the bladder, they're very close to the ureters. Okay, and they can be damaged or injured during gynecologic or obstetric procedures. So the previous slides showed an overview of the female pelvic anatomy. The ureters run laterally or descend to the pelvis beneath the uterine arteries within 1 to 2 centimeters at the level of the cardinal ligament. So a relationship often summarized by the phrase water under the bridge. So ureter is under the uterine artery. This places them at risk during ligation of the uterine vessels in procedures like hysterectomy. So additionally, the ureters course only about 1.5 to 2 centimeters lateral to the cervix. Actually, in some books or in some studies, it could be as close as 0.5 centimeters, which makes them vulnerable during deep dissection, especially in cases of distorted anatomy from myoma, malignancy, or previous surgeries. The bladder, on the other hand, lies anterior to the uterus and is particularly susceptible to injury during lower uterine segment operations, like in CS, especially in patients with prior deliveries where adhesions may tether the bladder to the lower uterine segment. Bladder injuries most often occur during dissection of the vesicouterine fold or during attempts to separate the bladder from the uterus. So this is why thorough preoperative planning, an understanding of variant anatomy, and careful surgical technique are essential, even in procedures we perform every day. So we always have to be reminded. Just to give you a visual idea, so look at this picture. Take hysterectomy, for example. So when we remove the uterus, you can see here, we have to carefully dissect it away from the bladder, which sits just in front of it. So you can see in this image how closely these structures are related. Actually, the space is really not this big. So on the other image, you can see here, showing a salpingo-oophorectomy. So we remove the adnexa, the fallopian tubes, and the ovary. The ureter, this yellow one, runs very close to the adnexa. So that means any traction or dissection in this area carries a risk of ureteral injury. These visuals really highlight how tight the anatomy is in the pelvis and why even routine procedures require careful attention to avoid genito-urinary complications. So let's talk about ureteral injuries. It is quite difficult to detect during surgery and are often missed intraoperatively. In many cases, the first signs only appear post-operatively. Patients may present with nonspecific symptoms like flank pain, fever, and lab work may reveal elevated creatinine levels. Imaging might show hydronephrosis, and in cases where a fistula develops, there may be leakage of urine from the vagina. So recognizing these red flags early is key to preventing long-term complications. And moving on to another important genitourinary complication, we have bladder injury. And though rare, occurring in about 0.25 to 0.9% of CS and hysterectomies, it's a complication we always have to watch for. Because most bladder injuries happen during entry into the peritoneal cavity, especially in patients with prior surgeries, because there are a lot of adhesions, which may distort the normal anatomy. Early recognition is crucial to avoid long-term morbidity similar to that of ureteral injuries. So before performing any OB-GYN procedure, it's essential to assess conditions that could increase the risk of genitourinary complications. And these include prolonged labor with bladder distension. So we always ask if nakaihi na nga ba yung pasyente or nahihirapan bang umihi? Because in that case, we could insert a Foley catheter to drain the bladder. Pregnancies with scarred uterus, as I've mentioned, or other scarring in the uterus like myomectomy or metroplasty, and cases wherein there are expected intra-abdominal adhesions like pelvic inflammatory disease or abdominal pelvic tuberculosis, any previous surgeries for that matter, even appendectomy. So we have to anticipate a difficult surgery. We should also be cautious when anatomy is distorted by fibroids or congenital anomalies like duplicated ureters, or let's say diverticulum, bladder diverticulum, even obstructed labor, so as simple as vaginal delivery. So we really have to be wary. Special attention is needed in advanced labor, as mentioned, with a low fetal station or in a high-risk procedure like CS hysterectomy. So recognizing these factors early can help us plan safer, more strategic surgeries. But at the same time, this would also help advise or counsel our patients of the potential risk, actually more elevated risk, given the following conditions. So in hysterectomy or CS, careful opening of the vesicouterine peritoneum is key to avoid bladder injury. It has been mentioned several times, but it's not as easy as it sounds. Actually, in scarred uterus or those with repeated cesarean deliveries, adhesions can make bladder dissection more challenging. So it increases the risk of injury. So in these situations, blunt dissection may actually do more harm than good. So instead, sharp dissection using met scissors is recommended to carefully separate the bladder from the uterus and reduce the risk of accidental cystotomy. So when discussing genitourinary injuries, the focus often falls on abdominal hysterectomies and CS, as I've been mentioning them multiple times during the past few minutes. But we must not overlook vaginal hysterectomy. So in vaginal surgery, the limited visualization of the ureters demands even greater surgical precision. And once the peritoneum is entered, the ureters can be palpated vaginally. But this requires experience, proper traction, and the support of a skilled assistant. So additionally, we should remember that bladder injuries can also occur during anterior colporrhaphy, particularly in pelvic organ prolapse repairs. And these risks highlight the importance of meticulous technique and anatomical awareness in all routes of gynecologic surgery. So this is how a bladder injury looks like intraoperatively, with a Foley balloon peaking or readily visible. But this is one example wherein it could be readily detected. In this instance, the defect is quite large, but in some cases, it could just be a nick. So it's quite negligible, or a sub-centimeter defect. The thing is, it is very crucial to recognize that while many bladder injuries are caught intraoperatively, some are missed and present later. Post-op signs we should watch out for include suprapubic pain, which could be mistaken as UTI, hematuria, urinary retention or incontinence, poor urine output, and in some cases, urine leaking from the vagina or surgical wound. So always keep a high index of suspicion, especially after difficult dissections, dense adhesions, or emergency procedures, because early recognition can prevent serious complications like fistula formation or infection. So if a bladder injury is missed intraoperatively, sometimes it may result to a vesicovaginal fistula. And this presents with continuous watery vaginal discharge, or mistaken as incontinence, or sometimes even mistaken again as UTI, because that's very common. So evaluating a suspected genitourinary fistula involves a multi-pronged approach. It entails detailed history, physical examination, and workups. So when we talk about detailed history, it's important to go beyond asking about prior surgeries, unless of course it's quite recent or within the year. Genitourinary fistulas aren't limited to CS, or hysterectomies. They can also occur after complicated vaginal deliveries, particularly in cases of obstructed labor. As shown in this picture, you can see prolonged pressure from the fetal head can compress the anterior vaginal wall, bladder, and even the sacral area. Now, this sustained pressure can cause tissue ischemia, leading to necrosis, and ultimately a delayed presentation of a fistulous tract. So, keeping this in mind is key when evaluating postpartum women with urinary complaints. Sometimes it's not all about having UTI. Now, this picture shows us the general location of genito-urinary fistula in sagittal view. So you can see here, urogenital fistula is named based on the specific organs involved in the abnormal connection, typically including terms like vesicovaginal, meaning there's connection from the bladder to the vagina, urethrovaginal, urethra to the vagina, depending on the location of the defect or opening. So essentially, the first part of the name indicates the origin of the fistula, and the second part indicates where it drains to. And this is how it would look like on pelvic examination. So on the left, you see here a stent inserted through the vaginal defect, probably involving a ureteral defect or ureterovaginal fistula. And on the right, we have here a vesicovaginal fistula. The red area is actually the defect. So if we suspect a genitourinary fistula or any related complication, the first step is to confirm the diagnosis and assess the patient's overall status. So as mentioned, we should always have a high index of suspicion. So we typically start with basic laboratory workups, and that includes CBC, which can help us check for any signs of infection or anemia, which may be present if there's ongoing leakage or chronic inflammation. A metabolic panel is useful for evaluating kidney function and electrolyte balance, especially if there's suspicion of ureteral involvement or impaired drainage. Definitely, we also request for urine studies, including urinalysis and urine culture, to detect any underlying infection or hematuria. Now, these tests give us an initial picture and help guide both conservative and surgical management moving forward. When evaluating suspected genitourinary injuries, imaging plays a key role in confirming the diagnosis and guiding management. So aside from the previous workups mentioned, the first line modality is often an ultrasound, especially in the immediate post-operative setting. Why? Because it's quick, non-invasive, and can help detect fluid collections, hydronephrosis, or bladder abnormalities. But if we want a more detailed assessment, we then turn to CT urography or CT urogram, which provides excellent visualization of the kidneys, ureters, and bladder. It's especially useful if we suspect a ureteral injury or leak, as it allows us to see contrast extravasation. When evaluating for fistulas, particularly vesicovaginal or ureterovaginal fistulas, a cystogram or voiding cystourethrogram is valuable. It can show the exact site of leakage during bladder filling or voiding. But if available and funds is not an issue. For more complex or subtle cases, MRI, especially MRI urography, offers high resolution, soft tissue contrast, and can clearly delineate fistula or surrounding inflammation, which is helpful in preoperative planning. So in summary, we choose imaging based on the clinical context. So ultrasound for quick bedside assessment, CT or MRI for detailed anatomy, and contrast studies for direct visualization of leaks or fistulas. But there's one simple but effective bedside test for diagnosing vesicovaginal fistula, and that's the double dye test, also known as the tampon test. So in this method, we give the patient an oral orange dye. So in the Philippines, we usually use rifampicin, which colors the urine orange. So at the same time, we instill methylene blue, as the blue dye, directly into the bladder. So a tampon or gauze is then placed in the vagina. So if we later see blue staining, that suggests a fistula from the bladder. If the staining is orange, it points to a ureterovaginal fistula since the dye passed through the kidneys and bypassed the bladder. So it's simple, low cost, and informative test that helps us localize the source of the leak before imaging or surgery. But of course, diagnostic cystourethoscopy is still the gold standard. We need to have direct visualization of the defect. Another important but often under-recognized genitourinary complication is voiding dysfunction, particularly after vaginal deliveries. This condition can be quite complex, stemming from a mix of factors. So we have perineal trauma, especially from assisted deliveries with the use of forceps or vacuum, which may damage the pelvic floor or pudendal nerve, making it harder for the bladder to empty properly. Epidural analgesia or anesthesia can also contribute by temporarily blunting bladder sensation and weakening the detrusor muscle activity. Now, the risk increases with prolonged labor, macrosomia, and multiple gestations, all of which can stretch or weaken the pelvic floor support. Because these factors often overlap, diagnosis can be quite tricky. And that's why careful postpartum monitoring is key to catching voiding dysfunction early and avoiding long-term complications. Anesthesia, as said, overhydration, medications, neurologic injury, and mechanical trauma can cause urinary retention or overflow incontinence or frequent urination by affecting the detrusor muscle function, nerve pathways, or bladder or urethral integrity. So post-operative monitoring, it should be emphasized, is very crucial. Preventing genitourinary complications during OB-GYN procedures requires a proactive and multifaceted approach. So it begins with a thorough preoperative assessment to identify patient-specific risk factors. That was already mentioned. For high-risk cases, targeted imaging can help map out anatomical variations and guide safer surgical planning. In particular, prophylactic ureteral stenting may be considered to help identify and protect the ureters, though this must be weighed against potential risk like infection or irritation. Actually, it's a good thing to involve urology or urogynecology, especially in challenging cases, providing collaborative expertise that enhances patient safety. Most importantly, meticulous surgical technique remains a cornerstone of prevention. So this means sharp dissection, clear identification of anatomic landmarks, gentle tissue handling, and cautious retraction, all of which reduce the risk of injury and support better outcomes. Deep understanding of the female pelvic anatomy is very important, and we cannot overemphasize this. As much as possible, avoid deep thermal spread in the use of cautery. So learn when to use coagulation as well as cutting. So suppose there's already a genitourinary problem or injury. Often, this can be a very big burden to not only to the patient, but also to the admitting physician. But the initial management can be remarkably straightforward and highly impactful. So studies have shown that timely and basic interventions can greatly reduce morbidity and the need for complex surgical repair. For instance, vesicovaginal fistulas or VVFs. It's a common iatrogenic injury. It may present days to weeks post-operatively, often with urinary incontinence. So if we do early and continuous bladder drainage via a large bore Foley catheter, 2 to 4 weeks probably, it has been shown to spontaneously close small defects. Now, this conservative approach is simple, yet powerful when applied promptly. If ureteric injury is suspected or confirmed, urgent referral to urology is crucial. Ureteral stenting performed early may obviate the need for major surgery and allows for ureteral healing. So basically, if we have high suspicion and we try not to deny the possibility of having genitourinary complications, we can address the problem promptly, and that early intervention is very important. So suppose there's continuous watery leakage per vagina. So perineal skincare is another essential yet often overlooked component. Dermatitis from constant urine leakage should be addressed with meticulous hygiene, barrier creams, and antibiotics for secondary infections, minimizing patient discomfort and infection risk. So when conservative method fails, typically if the leakage persists after 6 to 12 weeks, surgical intervention becomes necessary. The choice of surgical approach, whether it's transvaginal or transabdominal, is tailored to the fistula size, location, and complexity. How about voiding dysfunction? The management of voiding dysfunction requires a personalized approach focused on optimizing bladder emptying and reducing complications. So key strategies include catheterization, it could be indwelling or intermittent, bladder retraining to increase bladder capacity and reduce urgency, and referral to urodynamics and pelvic floor rehabilitation to diagnose complex cases and strengthen the pelvic floor muscles. Now, these strategies can be combined for optimal results depending on the individual's specific needs and diagnosis. A thorough evaluation is crucial for creating an effective treatment plan. Open communication and shared decision-making are crucial for successful management of genitourinary complications in OB-GYN procedures, and this involves fostering open dialogue between the multidisciplinary team and actively including the patient in decisions regarding their treatment plan, which ultimately leads to better patient outcomes and adherence. So genitourinary injuries, though rare in OB-GYN procedures, can lead to serious complications. Prevention and careful surgical planning, anatomical knowledge are key. Early detection and proper management are essential to avoid long-term issues. That's one thing we really want to avoid. And collaboration and shared decision-making improve patient outcomes. Again, note that even the most skilled and experienced obstetrician gynecologists are not immune to genitourinary complications, and these events can arise from a variety of factors. It could be anatomical variations, complex surgeries, patient factor, or even seemingly routine procedures. Despite our best efforts, they remain one of the most dreaded complications in our field. Why? Because no one wants to be the surgeon associated with a urinary tract injury, a fistula, or a missed uretary transection. Now, these outcomes can be devastating for the patient and emotionally taxing for the clinician. That's why understanding, anticipating, and managing these complications is not just essential, it's our professional duty. So that's it for the lecture. We hope to invite everyone to our upcoming convention for the Philippine Society for Urogynecology and Reconstructive Pelvic Surgery. You can also visit our website. If you have any questions, feel free to ask them in the chat box. Thank you very much for listening.
Thank you very much, Dr. Rani Cadiz, for your very extensive and very easy to understand lecture. So
Thank you
I
po.
hope for our audience, you can put your questions in the chat box or also in our Q&A portion, which our speakers will reply to. And is Raymond? We will go to our next speaker. Our reactor is Dr. Ira Dominic Malonzo, who is the training officer of the Division of Urogynecology and Pelvic Reconstructive Surgery at the UPPGH Department of OB-GYN. The floor is yours, Dr. Ira.
Good morning. Magandang araw po sa ating lahat. Una po, salamat po sa TVUP imbitasyong ito at congratulations Dr. Cadiz. Very grounded presentation on focusing on possible complications of the genito-urinary tract after these procedures, no? Part of it was also a reality check na may balance dapat yung ating technical skill, yung judgment natin, and a bit, you tackled a bit on professional accountability also, no? So, nasabi na ni Doktora, bakit kami we're very careful our surgeries because anatomy. Yung course nga ng ureters, ng bladder, napakalapit din kasi sa uterus tsaka sa adnexa. Lalo na po kapag we have adhesions, no? There's a distortion of the anatomy, kung complex yung naging obstetric or medical history ng pasyente, or if it's an emergency, like for instance, we see a lot of this cesarean sections that are done when they're in advanced labor, no, that really increases the risk for bladder and ureteral injuries. But I think what is most striking in Dr. Cadiz's lecture that I got was even in the most routine of our procedures, and even in the most routine of OB-GYN procedures, like say a hysterectomy, a repeat CS, a CS, it really does have surgeons can encounter complications. Now, I would like to also mention that surgical complications are not always a sign of poor skill. They can happen po kahit pa meticulous yung technique, kahit we have complete knowledge of anatomy and we have years of experience. Experience reduces the risk, but it never really eliminates the risk of complications. So, yung injuries po na ito, ang mahalagang kailangan, I think, take away ng ating mga manonood, no? They don't always present immediately, no? They don't always present right after any OB-GYN procedure. They can have subtle signs. It can present as persistent infections, say persistent UTI, persistent vaginal infections. It can just be voiding dysfunction, no? Baka ano lang, parang mas dumalas yung pag-ihi ko or parang mas hirap akong umihi ngayon, maaring ganon. Maari ding may makirot, unexplained, no? Hindi na normal yung pagkirot ng ating likuran, yung flanks or even the surgical site. There's delayed recovery at lalo na po kapag sa mga repeat na labs, abnormal yung values, talagang warning signs na yon. Okay. Now, I'd also like to take it to our local context and our experience, no? In our government hospitals po, not all, no, but they're really high case volumes. So we sometimes work under pressure, sometimes there are limited facilities that really make it harder for us to prevent or catch these injuries in a timely manner. Minsan po, in some provincial or say district hospitals, our OB-GYNs perform these procedures without access to more advanced imaging, no? So sometimes our clinical vigilance. So we really do teach early recognition and clinical vigilance because it is really the simplest and the best tool we have. But I think beyond the anatomy and the technique, we need to look at patient experience also and what we can potentially do when these complications occur. Yung pag-disclose po, hindi lang po yan mahirap para sa pasyente, mahirap din po yan sa doktor. No? But if we truly look at silence is really heavier than the complication. Why? Incontinence po, yun yung pinaka of our complications, no? Yung persistent urinary leakage. It is what they call sabihin sa post-op, for example, siya palagi or hindi niya alam but feeling niya panay-panay yung pag-ihi niya, hindi niya pa naman gustong maihi. Nahiya siya magsabi kasi tinitiis niya lang muna, no? So, or yung mga babaeng medyo hirap umihi, minsan iniisip lang, normal siguro to na nangyayari after tayong manganak. Okay. unstable. I hope I'm coming in clear. Normal siguro to na resulta ng panganganak. So, meron din talaga siyang psychosocial toll. There's some embarrassment that comes with it. Sometimes these women who are terribly incontinent have some social withdrawal. And we've had patients po, no, that they are abandoned by some of their family members, particularly their partners, because of all of these possible post-op complications. So life-altering conditions talaga. So this is really why I appreciate lectures like this, of the opportunity for us to lecture in fora like this, no? It's very important, hindi lang po para sa aming mga professionals, but for everybody, for educating women, families, and our communities. On our end po, we would like you to know that we really do strive for technical excellence, no? Pero tinuturo din po namin yung courage in our honesty, humility in our practice, and always po patient-centered yung response natin. So we want to move towards a healthcare system where any woman feels safe to be able to tell a healthcare professional about her symptoms, no, without any shame. So, and I think that can start with teaching the barangay health workers and educating women about normal recovery and what to expect, what is normal, what is abnormal. This fora also helps us reduce the stigma that's associated with these symptoms, because we would like I would like to reiterate that our commitment, at least in our division, our commitment really is to remind every woman that your condition, if you deem it uncomfortable, it has a name, and that there is treatment. You just really need to have the courage to also be seen. Maraming salamat po, and we are welcome to answering any question.
Thank you very much, Ira, for your lecture. And I hope the audience, no, you listen to it, and yung stigma attached to it, yan yung yan yung nahihiya yung mga patients to come forward. Kaya nagtatagal ang condition nila. My question is for Dr. Rani. Rani, what do you think of, kasi yung mga may medical conditions such as diabetes, talagang meron silang parang incontinence dahil sa situation ng diabetes. Is that a major obstacle for you? Paano yan address sa mga patients nyo
Urinary incontinence po.
na
We have
the
to
diabetic?
Yes, but first we have to rule out the possibility of chronic urinary retention, which can be seen in patients with uncontrolled diabetes mellitus. If you've heard or if you're familiar po with diabetes cystopathy, it could also blunt the sensation of the bladder, and it would also affect the contractions of the detrusor muscles. So sometimes they may complain of urinary frequency, well, not just because of the elevated sugars in the blood, but because of the urinary retention. That's one thing we really have to rule out. So for a workup, probably po, the best, aside from controlling the sugars, no, and getting the HbA1c, 75 grams of OGTT, the best is to get not just the KUB ultrasound, but check also the pre and post void. So yun po, we need to rule that out because that might be a reason for the incontinence.
I have another question naman for Ira. For mga cancer patients, I'm sure you have this problems also that the cancer patients usually after radiation, mga ganon, so nagkakaroon sila ng urinary problems. What do you do with those patients?
Thank you, ma'am. We have something called radiation cystitis, no, ma'am. Usually because of all the fibrosis, I believe you must be pertaining to, say, cancers of the
Uterus or
genital
ovaries?
tract, ma'am, di ba? So yes po. So they often present with symptoms of frequency, urgency, kumbaga the irritative symptoms, because there's a difficulty in terms of storage. So in those cases, ma'am, we assess the degree of the severity of bother of the symptoms, and then we go by the symptom first. Of course, this is with the assumption that we have ascertained that indeed the symptoms are simply because of the prior radiation, say, or the prior treatment for the cancer. So, dapat po na na-rule out na yung ibang mga posibleng sanhi ng mga sintomas niya, no? So, pag ganun po, we do assessment of how severe the symptoms are, and we can do anything within the range of supportive therapy, say bladder training po, yung timed voids. We can also or beta adrenergic agonists to help their bladder be able to hold more. And then beyond that po, we also can intervene surgically kung talagang intractable yung kanilang leaking in post
Oo.
treatment for cancer.
Hindi ba, Ira, pagka mga cancer patients that undergo radiation, di ba nagkaka-strictures yan sa ureter? So, paano ginagawa dyan?
Pag ureters, ma'am, we will refer to our colleagues in urology. But if it's urethral strictures po, ma'am, if it's urethral strictures, we assess first kung ano yung degree ng obstruction, no? And then we can do some procedures if indeed upon workup, and our workup will go from anywhere from the range of testing residual or a uroflowmetry po, no? Uroflowmetry is a test for bladder function. So tinitingnan namin how poor the emptying is, probably because consider surgical intervention, dilation, and of course, making sure that even post the intervention, ma'am, we keep it patent. So, yeah, so I think it's more of establishing first the patency of that the
Ureter.
urethra. Yes, ma'am.
Ah,
But pag ureter po, ma'am, we refer to our colleagues in urology. Yes po.
There's a question here from Dr. Joseph Tortona. What is the incidence of ureteral obstruction / stricture after C-section and open laparoscopic tabiso? Incidence of ureteral.
Ureteral injury or obstruction from cesarean delivery is really, really low because the ureter is is at the back of the uterus. It's an organ that cannot be readily seen naman po. Nasa gilid siya talaga. So I guess yung open or laparoscopic hysterectomy study shows as low as 0.2 to 0.78 usually po. Unless, of course, that's the average po. But remember, the statistics may be low because they are not readily reported. So we have problems in terms of documenting those problems or those cases.
Alam mo, since your division has the most number of these patients, siguro it will be nice to have like a manual that you can share with other doctors, no? I mean, more research or yung mga patients nyo, yung inyong patient base, kasi they are all parang fonts of knowledge, eh. What you experience from them, you can share with others also. So, you can even write a book about this. Really, yung experience ng UPPGH, alam nyo, for our audience, itong division nila is very unique. There is none other in the whole Philippines na may ganito. Merong Uro-GYN division, ano. So, I think if there are no more questions from the floor, let us see yung ating mga questions na ina-ask natin sa mga audience. Ton, can you flash our... Yeah, okay. So we have the first question is the panelists demonstrated thorough knowledge of the topic, and the answer is okay, strongly agree ang audience. The second question, the panelists were well prepared and organized. Strongly agree then ang audience. The panelists spoke clearly and audibly. Again, strongly agree. Number 4, the panelists used appropriate language with technical medical jargons and adequately explained. Again, strongly agreed. And lastly, the panelists contributed to new perspectives and knowledge on managing various key health issues. Again, strongly agree. That's the end of the poll. And then, yan, andyan na si Raymond. Raymond, take over.
Thank you. We'd just like to thank Dr. Rani Cadiz and Dr. Ira Alatraca Malonzo for really giving their, sharing their time, their insights po, particularly for this webinar. Not many of us kasi know about this genito-urinary complications po, no? So, on behalf of the webinar team, we thank the Philippine Society for Urogynecology and Reconstructive Pelvic Surgery for this excellent webinar po, no? I'd like to take this opportunity to greet those who have been joining us, or at least have indicated that they are joining us. Let me just pull out the those who have joined us from the National Kidney and Transplant Institute in Quezon City, the Region 2 Trauma and Medical Center in Bayongbong, Nueva Vizcaya, Baguio General Hospital and Medical Center in Benguet, Oriental Mindoro Provincial Hospital in Calapan City, Oriental Mindoro, Bataan General Hospital Medical Center in Balanga, Bataan, those from the province of Laguna, the Philippine General Hospital, obviously, Davao City, Cebu City, the province of Rizal, Antipolo specifically, Santolan Physical Therapy Center. Maraming salamat po. Shout out also to Team Sutra and Team Sarantis. Maraming salamat po for your avid viewership and participation. And then internationally, we are also being viewed by the Chonin Hospital, Taipei City in Taiwan. And this one, very new, the Al-Hada Armed Forces Hospital in Al-Hada, Saudi Arabia. And Saad Dalab University of Blida 1 in Blida, Algeria. Okay, maraming salamat po. Dr. Stella, because we've already put out the evaluation poll, who will be our speaker for next week, ma'am? And what's the topic?
For next week, we have Dr. Annabel Herrera, who is a prominent obstetrician gynecologist, and she will be our lecturer. And also with Dr. Butch Manalastas as reactor.
Okay, thank you so much. We can't wait to have that episode for next week. Again, we like to thank everyone. You can still watch us on the playback at the TVUP YouTube channel and at TVUP Signal TV channel 101. Before we conclude our program for today, for the week, all health updates webinars are archived for viewing at the TVUP YouTube channel. So you just go www.youtube.com/TVUPPH. And you'll be able to see all of our 245 webinars. After today, it will be 246. That's in the live tab. Now, if you go to the shorts tab, in the shorts tab, you'll be able to see selected presentations that we feature in snippets po, no? So those are something that hopefully will give you nuggets of wisdom po, no? Maybe you're waiting for your coffee, just like me, are waiting for your transportation vehicle to arrive po, no? These are very short and very learning field short videos po natin. Okay, this formally closes our webinar for the week. Makita-kita po tayo ulit next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, have a good weekend, everyone, and see you online.